Now, I will invite Dr. Salina Akther, who will talk. She will talk against SGLT2 inhibitor in non-diabetic kidney disease. Dr. Salina Akther, please.
Honorable Chairperson, learned audience, ladies and gentlemen, Assalamu alaikum and very good morning. I am Dr. Salina Akther, Associate Consultant of Nephrology in United Hospital Limited. At first, I would like to thank Dr. Ushan Sari Bhai to giving me the opportunity to say something in front of such a wonderful audience. SGLT2 inhibitor is a novel drug, already said by my opponents, and this is a very newer drug, and it creates a revolution in management of type 2 diabetes. And a very recent ADA guideline 2023, which was published in 12th of this December, they included this drug as a first line of treatment with metformin, especially in compelling indications like heart failure, CKD patients, high-risk population like atherosclerotic cardiovascular disease, and including the high-risk population including more than 55 years of age. From my previous speaker, we already know that it has many beneficial effects, and which was proved in both clinical and preclinical trial. And on the basis of emerging evidence, SGLT2 inhibitors are now transforming the management of heart failure and CKD patient, including without diabetes. So now, nephrologists will play a key role to prescribing this drug for its renoprotective effect. We all know that it acts on proximal convoluted tubule and causing glycosuria, which is in diabetic patient more than 100 gram per day, and in non-diabetic patient 50 to 60 gram per day. But this effect becomes minimized when GFR goes less than 30. So as a nephrologist, we should know where we should be more cautious and where we should stop, as every drug has pros and cons. About treatment of SGLT2 inhibitor, our first concern is infection. And all the study shows that there is an increased incidence of infection in patients treated with SGLT2 inhibitor. And genital mycotic infection is more common. It increases the risk 2 to 4 fold in patients treated with SGLT2 inhibitor, which is more common in first month after the starting this drug, and common in women and the patient having the prior history of genital mycotic infection. We can reduce this risk by counseling our patient to maintain the hygiene, to keep the genital area dry, and we can also consider prophylactic antifungal drugs in high-risk population. In 2018, US FDA identified 55 unique cases of Fournier's gangrene in patients receiving SGLT2 inhibitor. And they recommend we should stop this drug when the patient suffers from Fournier's gangrene. Another complications is recurrent and complicated UTI, which is a very common topics to us, like nephrologists, and they recommend it should be used with cautions, especially in patients suffering from chronic indwelling Foley's catheter. The Canvas program is a big trial of SGLT2 inhibitor. They raised a concern regarding the association between the canagliflozin and minor and major amputation. For this reason, it got black box warning for amputation by FDA. But very recent trial, Credence, report a similar incidence of amputation in both canagliflozin and placebo group. Another real-world meta-analysis comparing the canagliflozin and other anti-hyperglycemic agent did not find any association of amputation. Though they recommend some recommendation to reducing the risk of lower limb amputation. The people taking which SGLT inhibitor, they should check their feet regularly and practice preventive foot care, like remove the callus and apply the emollient to their foot, and they should report any foot infection and ulceration. Clinician, that we should counseling our patient and provide education and emphasize the importance of good foot care when taking the SGLT2 inhibitors. We should avoid initiation of SGLT2 inhibitors if active foot ulceration, and be cautious in people having the peripheral vascular disease and previous history of amputation. Now consider stopping of this drug in case of active foot ulceration, osteomyelitis and gangrene. Another big concern in euglycemic diabetic ketoacidosis. The patient treating with SGLT2 inhibitor, there is a 7-fold rise rate of diabetic ketoacidosis. Among them, 71% had euglycemia. In a preclinical trial, even in non-diabetic rat, it shows the SGLT2 inhibitor exposed a treated patient with SGLT2 inhibitor exposed to a volume depleted stress and developed euglycemic diabetic ketoacidosis. It was thought that the SGLT2 inhibitor causing hyperinsulinemia by reducing the blood glucose level. They can also increase the glucagon level by stimulating the alpha cell activation. And all those factors leading to the ketogenesis. On the other hand, by causing the glycosuria and natriuresis, they increase the reabsorption of ketone body in the kidney. So, increase blood ketone body without increasing the blood glucose level. There is some predisposing factor in euglycemic diabetic ketoacidosis, like acute illness, dietary changes, preoperative and postoperative fasting, and low carbohydrate diet, underlying malignancy, and other conditions like cocaine abuse and pregnancy. So how can we prevent this? We can prevent this by SGLT2 inhibitor be held 2 to 3 days prior to the scheduled surgery. We must avoid more than 20% reduction of insulin dose. If it is done, we should monitor the patients carefully. Discontinuation of SGLT2 inhibitor during the episodes of acute illness like vomiting, diarrhea, inability to eat or drink. In high risk circumstances, we should keep an eye of the patient. They are more prone to develop the euglycemic diabetic ketoacidosis, and we can also consider urine ketone body monitor in this patient. As a nephrologist, our main concern is acute kidney injury by treating the patient with SGLT2 inhibitors. As FDA received from January 2013 to September 2016, they received 1,200 reports of AKI. Among them, 42% patients were hospitalized and 16 individuals died. Though, unfortunately, renal biopsy was not done in most of the cases. They presume that this underlying cause is due to hypovolemia and some reduced interglomerular pressure. So, renal biopsy was not done, but few cases renal biopsy was done. The 5 case reports was found that this drug is associated with osmotic nephropathy, which is characterized by presence of osmotically active substance in the tubular epithelium. In all this study, they excluded the other causes of osmotic nephropathy in these patients. And the largest trial, my opponent says, the DAPA-CKD and Credence trial, both of them, they shows that there is an initial dip of serum creatine level in all these patients, and it is more marked in 1 month after starting this drug. But in long-term effect, it is not affect the preservation of GFR in all these patients. So 30% reduction of GFR is accepted in this patient which are treated with the SGLT2 inhibitors. When we start a SGLT2 inhibitor, we should assess first the volume status and blood pressure of this patient. If the patient is hypovolemic, we should decrease the blood pressure medications along with diuretics by 20 to 30%. And then liberalize the fluid intake, and after that we can start SGLT2 inhibitor to reduce the risk of AKI. On the other hand, if the patient is euvolemic or hypervolemic, we can start SGLT2 inhibitors, its recommended doses, and we can continue their baseline ACE inhibitor, mineralocorticoids and other diuretics, but diuretics should be reduced if it is permitted 20 to 30%. And patients should be educated about their sick day and when to stop this drug if they feel any unwell. And we should monitor the patients after 1 month with the reports of electrolyte, carbonate, creatinine as per local guidelines. And we will accept 30% of serum creatinine, increase in serum creatinine. If it is more than 30%, we should stop the drug, reassess the patient, and if possible, stop other volume status and blood pressure drug should be stopped also. There is a limitation in all the study which done in previously as a randomized control trial. They don't include patient with CKD stage 4 and 5. So the benefit of this drug is not determined in this population. The patient with active immunosuppression prior to the 6th month of this trial, they are also not included. Patient with active disease, active immunological disease like lupus nephritis and ANCA-positive vasculitis was not included. The data remain scarce in transplant recipient. So we should explore the new field of this drug by doing further study. This is the message concluded. So thank you, sir, for your nice time.
Thank you, Dr. Salina Akther, for your talk.